Hello everyone. We were in the middle of going through myeloid neoplasms and looking at acute myeloid leukemia. By now, all of you would be certain that you cannot escape WBCs in MBBS. For that matter, as a doctor, you cannot escape WBCs. So, you should somehow make peace with WBCs. Now, as we have already seen, AML is a tumor of hematopoietic progenitors and causes accumulation of blasts in the marrow. And AML is more common in old age. AML is caused due to oncogenic mutations, which inhibits differentiation of WBCs, or basically myeloid series cells, and there is increase in myeloblasts, or the earliest form of myeloid cell. These myeloblasts are increased in the bone marrow, and since myeloblasts replace most of the cells in the bone marrow, the other hematopoietic cells are unable to function properly. They are not produced properly. So since RBCs are reduced, anemia occurs, platelets are reduced, thrombocytopenia occurs, and obviously neutropenia because of reduction of granulocytes. The main pathogenesis of AML is due to driver mutations. There are many mutations which have been identified. Nowadays, AML is classified according to these mutations only. So there are two types of mutations recognized, like four types, maybe broadly four types. One is inhibition of normal myeloid differentiation. We saw it here. And the most common ones are translocation 821 or inversion 16. Here run X1 is required for differentiation of WBCs. Run X1 binds with CBFB and forms certain proteins which are required for myeloid differentiation. But when there is a translocation of 821, this run X1 forms a chimeric protein. Chimeric protein is a protein derived by combination of two different types of proteins. A chimeric protein is produced which inhibits myeloid differentiation. Another important one is translocation 1517, which produces a PML RARA chimeric protein. It is seen AML M3 or APML, acute promyelocytic leukemia. The other type of mutation is pro-growth or increased survival. Again, translocation 1517. Here, FLT3 is produced. This FLT3 along with PML-RARA mutation produces AML M3. Other mutation is again TP53, which is pretty bad. It produces weird looking blasts, and even epigenetics play a part in pathogenesis of AML. Now we'll look at the major subtypes of AML according to WHO classification. Earlier AML was classified under FAB. Even FAB classification is used on ground even now because it's pretty easy and everybody understands it. But we like WHO classification is scientifically more valid. First class is AML with genetic aberrations. They are classified under one group because they have specific changes or clinical features and even therapeutic implications due to this genetic aberrations. First one is we saw earlier, it's translocation E21 run X1 plus run XT1 fusion gene. It has a good prognosis. They produce full range of myelocytic maturation. Now AML with inversion 16, again same one. Here the CBFP component is joins with MYH1. The other important one is AML with translocation 1517 or PML rara fusion gene. Since this has a propensity to produce pro-thrombotic cytokines, there is a high incidence of DIC in promyelocytic leukemia. Then the second broad class is AML with MDS like features. Here it can occur like AML can occur from an MDS, a patient with MDS going into AML, or AML with multilineage dysplasia. Don't have to go into details of these. Another category is AML therapy related. Earlier it was called as AML related to alkylator therapy, etc. Depending upon therapy it was classified, but now it's under one single category because it doesn't really matter what kind of therapy is used. Here therapy mainly means cancer therapy like alkylator therapy, radiation therapy, etc. After which AML can occur and the prognosis is pretty poor. Okay, before going into FAB, rest everything is classified as AML NOS. Now coming to AML NOS, it's almost as same as FAB classification, as you will see later. AML minimally differentiated without maturation, myelocytic, myelomonocytic, erythroid, megakaryocytic. Each has its own features, and all of these have intermediate prognosis. A few important things which you have to look at is AML minimally differentiated may be MPO negative. Then blasts of megakaryocyte lineage can occur in megakaryocytic AML. NSC is positive in AML with monocytic maturation, neuron specific esterase. FAB classification is almost same as this last category here. Difference being AML M3 is also included. M0 is minimally differentiated, M1 without maturation, with maturation, acute promyelocytic leukemia, myelomonocytic, monocytic, erythroleukemia, and megakaryocytic leukemia. Like I would like you guys to go through this and try to memorize. Now in AML, CBC shows anemia and leukocytosis, thrombocytopenia. Almost all AMLs present like this only. Anemia and thrombocytopenia will be there. On peripheral smear, there will be normocytic anemia. WBCs will show more than 20% blasts, and they are myeloblasts. But there is a condition called aleukemic leukemia, where bone marrow will contain more than 20% blasts, but the blasts may not have come out into the peripheral blood. Still, it is called acute leukemia. So, by definition, to call something acute leukemia, there should be 20% blasts in the bone marrow or blood or peripheral blood. These are the various morphological forms of myeloid cells, myeloblasts, according to FAB classification. The only thing which you have to look over here is that the myeloblasts are large cells. They have a moderate amount of cytoplasm, and the nuclei are nucleus shows irregularity, nuclear membrane irregularity, and multiple nucleoli are seen. These light staining regions are nucleoli, and chromatin is open, like it's kind of lighter when compared to a lymphocyte here. That is what is called as open chromatin. And these are different types of blasts. This blast is pretty important, this morphology. It is almost one of the few emergencies in pathology. When you see something like this, these things are overrods. These pink stick like things are overrods, and there are a lot of granules in the cytoplasm. And these are blasts, large cells with large nuclei, multiple nucleoli, open chromatin, granular cytoplasm, and overrods. APML or AML M3. Eosinophilic blasts, then M4, M5. Again, these look almost like monocytes. Coming to cytochemistry of acute leukemias, like MPO, myeloperoxidase, is positive in most of the AMLs, and PAS or periodic acid shift is positive in lymphoblasts, ALL. NSC, non-specific esterase, is positive for monocyte series. We saw AML M5 earlier. Now, MPO is a stain which we all use in the lab. It's important because it kind of helps us confirm it's an AML when the granules or overrods are not very prominent. This is how MPO stain looks like. These are all blasts. This is a nucleus. The cytoplasm has taken up myeloperoxidase, the black color. Yeah. How do we differentiate lymphoblast versus a myeloblast? Lymphoblast is slightly smaller. Cytoplasm is lesser. That is, NC ratio is high. Then nucleoli are less in number and inconspicuous, less prominent. Nuclear chromatin is coarse. Here it is fine. And MPO is negative in lymphoblasts, positive in myeloblasts. PAS is positive in lymphoblasts. Yeah, it's a good representation of myeloblast versus a lymphoblast. Here, the myeloblast, you can see this is representing an overrod, cytoplasmic granules. large nucleus, multiple nucleoli, lesser cytoplasm, coarse chromatin, okay, lesser number of nucleoli. Okay, that was AML. Now coming to MDS, or Myelodysplastic Syndromes, which is the second myeloid neoplasms which we are looking at. MDS is quite unique. It is by definition, MDS is myelodysplastic syndrome is caused due to clonal stem cell. It's a clonal stem cell disease where the cells have a maturation defect. So there is ineffective hematopoiesis, and any of the MDS can convert into an acute myeloid leukemia. So what happens because of all these things? Because of ineffective hematopoiesis caused due to driver mutations due to various things, TP53 mutation, transcription issue, RNA splicing blockade, and epigenetic factors are also involved. Because of all this, you can almost call this a pre-neoplastic phase or something, where clonal chip, it's called chip, or clonal hematopoiesis of indeterminate potential occurs. From that, MDS forms. The issue in MDS is not the number of cells. If you see the bone marrow, actually it will be cellular, lot of cells will be there, but the problem is whatever cells are produced are ineffective, they're not good. So they are like destroyed in the bone marrow itself. So there is a peripheral blood cytopenia. It's a weird condition where marrow is cellular and peripheral blood shows no cells. Now there are two types of MDS. The primary one, which we are the one under discussion is the primary one. Secondary one has all the features of primary, only thing is it occurs after therapy, chemotherapy or cancer therapy or something. It's got a worse prognosis as it can convert to AML faster. MDS usually occurs in older individuals, and prognosis is intermediate. Around 5 years of lifespan can be expected without intervention. But anyway, intervention is also difficult. It is not, there are no useful drugs as such. Maybe hematopoietic stem cell transplantation can be thought of, but it depends on the patient's health and age and all. Coming to morphology of bone marrow. Bone marrow, as we already saw, is hypercellular, and we can see ring sideroblasts. Yeah, these are like there are iron deposits around the nucleus like a ring in erythroblasts. Then megaloblastic change will be there, may be there, and nuclear budding can be seen. And one nice change in megakaryocyte is pond ball megakaryocytes, like like multiple lobules will be there, but in this shape of different balls, and blasts may be present but less than 20%. Okay, here you can see multinucleated erythroid cells, which is dyspoiesis, basically sign of dyspoiesis. Pseudo Pegler-Huey abnormality, only 2 lobes of neutrophils, and there is hypogranulation of neutrophils, again sign of dysbiosis. These are ring sideroblasts. Here you can see megakaryocytes with multiple nuclei instead of a multi-lobulated nucleus, pond ball megakaryocytes. Okay, that was MDS. Now coming to myeloproliferative neoplasms, MPN. MPNs have some common features. All of them show most of the times proliferation of cells in the bone marrow, and then at a later phase extramedullary hematopoiesis, especially in the spleen and liver, and then they enter something called a spent phase, where there is marrow fibrosis and cytopenias, and any of the myeloproliferative neoplasms can go into an acute leukemic phase, and all of them have mutations which activate tyrosine kinases, different types of tyrosine kinases, and there is GF independence. GF is growth factor here. Now, classification of MPN. Basically, MPN is classified into two types. One is BCR-ABL positive, BCR-ABL negative. And BCR-ABL positive MPN is CML, or chronic myeloid leukemia. And BCR-ABL negative can be different types like Polycythemia Vera, ET, PMF, etc. Yeah. So these are the myeloproliferative neoplasms. This chronic myeloid leukemia, where BCR-ABL fusion gene will be there in all CML. Like, to call something CML without BCR-ABL is difficult. It's like all CMLs will be BCR-ABL positive. So, in contrast, the other myeloproliferative neoplasms will be BCR-ABL negative. If other myeloproliferative neoplasms clinically, if you feel like it's Polycythemia Vera but BCR-ABL is positive, you still consider it as CML only. Now the other mutations which you have to look for is, one is JAK2, which is very important in Polycythemia Vera. Almost all cases of Polycythemia Vera will have JAK2 mutations. Then ET essential thrombocythemia can have JAK2, CALR, MPL mutations. Primary myelofibrosis, again similar. And other entities like systemic mastocytosis, chronic eosinophilic leukemia, and neoplasms, myeloid neoplasms with eosinophilia and TK gene mutations. Shows different types of mutations. Coming to CML, chronic myeloid leukemia. It is a myeloproliferative neoplasm. BCR-ABL fusion gene is there, BCR-ABL positive. Clinically, usually, most commonly, CML occurs in adults above 50 years, but it can occur at any age actually. Like nowadays, in India, it is said that the average age at which CML is occurring is reducing. it's reaching the 40s and mid 30s. CML is an insidious like its onset is insidious. It's a slow growing. Usually it takes around 3 years to 4 years to go into blast phase, which can end in bad prognosis. Basically there is increased metabolism due to increased cell turnover, which causes fatigue, weakness, weight loss, anorexia, etc. And splenomegaly is almost always there due to extramedullary hematopoiesis. There are 3 phases of CML. One is a chronic phase or CP, call it CML CP, where basophils and blasts are all less, and there is leukocytosis. Then chronic phase can enter an accelerated phase. You call something an accelerated phase when basophils are increased, or the blasts also increase, but less than 20%. Then almost all CMLs end up in blast crisis. You can call something blast crisis only when there is more than 20% of blasts in marrow or peripheral blood. CML can go into AML or ALL. It is thought that it is because CML arises from earlier progenitor cell than the myeloid one, probably below the hematopoietic stem cell. So that is why CML can go into ALL also. CML is treatable to an extent by BCR-ABL inhibitor called imatinib. Try to find out where else imatinib is used. Some other totally different neoplasm also can be treated with imatinib, or you can say contained with imatinib. This is the BCR-ABL fusion gene or chimeric gene, whatever. BCR is in chromosome 22 and ABL from chromosome 922 translocation, and it forms a 210 KDA, kilodalton BCR-ABL fusion protein, which can dimerize. 2 of them can go together, and BCR causes this dimerization, and ABL is activated once dimerization occurs, and once ABL is activated, JAK-STAT pathway, RAS, STAT, AKT, everything is activated. It causes increase in production of cells in the bone marrow. This is a peripheral blood picture of CML, where you can see different types of cell, all stages of maturation of granulocyte can be seen here. This is a basophil, the bands, neutrophil, bands, metamyelocyte, blast, not really a blast, it's a myelocyte. Okay. Yeah, even thrombocytosis can occur in CML, in peripheral blood, although here it almost looks like thrombocytopenia, but usually it can present as thrombocytosis also. Coming to the next entity, Polycythemia Vera. Again, it's a myeloproliferative neoplasm. BCR-ABL must be negative. JAK2 is positive in most cases. PV can present with increase in hemoglobin levels, which causes increased blood viscosity, and the platelets are also dysfunctional, you can say, or sometimes hyperfunctional. So it can cause thrombosis or bleeding, and at a later stage, Polycythemia vera can enter a spent phase where cytopenia can occur, then marrow fibrosis can occur. Usually marrow will be hypercellular to increase production of cells, and at a later stage marrow fibrosis occurs. PV can go into acute myeloid leukemic phase. Next is ET, essential thrombocythemia. ET is again a myeloproliferative disorder. Here JAK2 and CALR can be positive. Again, it occurs in older individuals. There is increase in platelets, but the platelets may not be fully functional, so it can cause thrombosis or hemorrhage. Another clinically important feature is erythromelalgia, where there will be itching, throbbing pain of skin. This erythromelalgia can occur in Polycythemia vera also. In fact, most of these PV patients present with pruritus and all, itching. ET. In ET, there should not be any polycythemia or marrow fibrosis, and increase in platelets will be there. If polycythemia is there, then you are thinking more in terms of PV. Marrow fibrosis, again PMF, primary marrow fibrosis. Bone marrow will show staghorn or large atypical megakaryocytes, and peripheral blood can show thrombocytosis with giant platelets. Primary myelofibrosis. Any of these previous myeloproliferative neoplasms like CML, PV, ET, etc., all of them can go into myelofibrosis. But this is a different entity where there is clonal proliferation of megakaryocytes in the bone marrow. These megakaryocytes produce factors which causes increased fibrosis of the marrow. Clinically, there will be anemia and leukoerythroblastic picture, which means leukoerythroblastic means left shift of WBCs, means is a myelocyte, and this is a nucleated RBC. So this kind of a picture is called a leukoerythroblastic picture. And this one is a teardrop cell. Teardrop kind of RBC is formed when red blood cells try to get out of the marrow through the fibrous spaces. Here JAK2 mutation may be present, and many cases of primary myelofibrosis can end up as AML. Now, in the first stage of myelofibrosis, there will be a increase in megakaryocyte and myeloproliferation, mainly megakaryocytes. Then there is because of factors released from megakaryocytes, there will be reactive bone marrow stromal changes, whereby fibroblasts and osteoblasts are increased. And once the marrow is completely fibrosed, or fibrosis increases, the hematopoiesis shifts to places outside the marrow. So it causes extramedullary hematopoiesis, especially the spleen. This is a bone marrow biopsy picture of primary marrow fibrosis. You really can't see any fibrosis here per se, but like these show early phase where you can see megakaryocytes with cloud-like nucleus. Usually megakaryocytes have that multilobated nucleus. Here it is almost like a cloud-like nucleus. There are two self-study topics. One is LCH or Langerhans cell histiocytosis, then thymoma. Now we'll go through your doubts and other topics in the live discussion session. Thank you all. It was a nice experience.